Welcome to the GMJ podcast, the official podcast of the Georgian medical journal Health and Migration series. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled Coexistent Bronchopulmonary Adenocarcinoma and Tuberculous Lymphadenitis, a Diagnostic and Therapeutic Challenge.
Thanks so much for having me on to talk about this.
Well, absolutely. It's a fascinating paper. So let's unpack this deep dive, because I want you to imagine looking at a medical scan, right? And it shows this massive, late-stage, supposedly inoperable lung cancer.
Right. A terrifying thing for any patient to see.
Exactly. You see the primary tumor, and you see that it's clearly spread into the surrounding lymph nodes. The clinical path just seems completely obvious.
Yeah, the textbook path.
Right. But now imagine finding out that this, multi-million-dollar imaging machine is completely lying to you.
Yeah, that's the core of this whole report. The visual evidence is real. But the biological story that visual evidence is telling you, it's a total fabrication.
Which is wild.
It really is. The patient isn't looking at an untreatable spread of cancer. They're actually looking at a localized tumor that's hiding behind completely separate treatable infection.
And that's exactly why we're stepping into this really murky diagnostic landscape today. We're exploring a medical mystery where two massive, completely different diseases decide to just, hide behind one another.
Diagnostic camouflage, essentially.
Exactly. And our source material for this, as we mentioned in the intro, is a newly published peer-reviewed case report from the Georgian Medical Journal dated March 2026.
And it comes from a really incredible medical team. It was authored by Ammar Bukat and colleagues from the military teaching hospital Mohammed V in Rabat, Morocco.
Right. And our mission today is to explore this dangerous phenomenon. We need to understand why peeling back the layers of what is hiding, what can literally be the difference between life and death for a patient.
Yeah, because the clinical scenario they document in this paper is basically a perfect storm.
It really is.
We're analyzing the rare coexistence of two formidable pulmonary diseases in a single patient.
Yeah.
So we have bronchopulmonary adenocarcinoma.
Which is a very severe type of lung cancer.
Exactly. And alongside that, tuberculous lymphadenitis, which is tuberculosis manifesting directly in the lymph nodes.
So conceptualizing how two completely different diseases can look identical on advanced medical scans is, it's tough. I was thinking about it, and diagnosing this is like listening to an orchestra, right?
Okay, I like where this is going.
And you're trying to identify if a discordant sound is coming from the oboe or the clarinet, but they're playing the exact same note.
Right.
You know something is wrong, you hear the bad note, but the acoustic source is just perfectly blended together.
That's a great analogy. The signals of the bacterial infection and the signals of the malignancy are essentially playing that exact same note on the scan.
But to understand why this overlap is so perilous, we have to look at the conceptual framework here, the global prevalence of these diseases.
Yeah, absolutely.
Yeah.
I mean, both tuberculosis and lung cancer are massive public health challenges on a global scale.
Huge.
But there's a crucial biological distinction highlighted in the text regarding how they actually interact with each other.
Right, because I know that doctors frequently see cancer patients who also have latent tuberculosis, right?
Yes, that's quite common.
And latent TB basically means the body has effectively stalemated the bacteria. The immune system has walled it off into this dormant state.
Exactly. It isn't causing active symptoms, but it's physically still present in the tissue.
But what's fascinating here is the coexistence of active tuberculosis and lung cancer in the exact same patient simultaneously.
Right, and that is surprisingly uncommon.
Wait, really?
Yeah, it is. Because when we talk about the immune system walling off the bacteria in latent TB, we're talking about the formation of a granuloma.
Okay, break that down for us.
Sure. So tuberculosis is caused by this incredibly stubborn bacterium. It has this thick, waxy cell wall.
It's like armored.
Exactly. Armored is a good word. When it enters the lungs, your immune system's first responders, which are called macrophages, they rush in and try to swallow and digest it.
But because of that waxy armor you mentioned, the macrophage can't actually break it down, right?
Right. The bacteria just survives inside the immune cell. It's like a Trojan horse.
Wow.
So the immune system shifts to plan B. It sends a swarm of other cells to completely surround the infected macrophages, building a literal cellular wall around the threat.
And that physical mass of immune cells and trapped bacteria is the granuloma.
You got it. In latent TB, that wall holds. it stays intact.
Hmm.
But in active TB, the bacteria break out and multiply, which causes massive inflammation and tissue damage.
So here's my question. If both of these diseases target the lungs, and tuberculosis is incredibly common in certain parts of the world.
Which it definitely is.
Right. Then I would expect them to show up together all the time. Like if the environment is saturated with TB and lung cancer rates are rising globally, shouldn't a compromised cancerous lung be the perfect breeding ground for an active TB infection?
It makes sense on paper.
Yeah, why is this paper treating their concurrent presence as such a clinical rarity?
Well, you're hitting on a logical assumption that actually masks a statistical reality.
Okay, how so?
While a compromised lung is vulnerable, finding a primary lung tumor concurrently progressing alongside a fresh, active tuberculosis infection in the lymph nodes it doesn't happen often in clinical observation.
Really?
Yeah, usually the aggressive symptoms of one completely outpace the other. Or, more dangerously, the obvious presence of one dictates the medical team's assumptions entirely.
Oh, I see. So if a patient walks into a clinic coughing up blood in an area with a high prevalence of TB, the doctors see the statistical probability and just immediately treat for TB.
Exactly. And the underlying cancer could progress entirely unnoticed.
Because the diagnostic momentum carries the medical team in a single direction.
Right. A massive, obvious threat is usually deemed sufficient to explain all of the patient's symptoms. The human brain naturally stops looking for a second assassin once it finds the first one.
That makes total sense. But here's where it gets really interesting regarding the core findings. Because the patient at the center of this Moroccan case study forces us to look at that second assassin.
Yeah, she does.
We're looking at a 71-year-old woman, and the paper makes a very deliberate point to note that she is a non-smoker.
Which is a huge detail. A
Correct.
71-year-old non-smoker presenting with severe respiratory issues naturally lowers the initial index of suspicion for lung cancer.
Right, compared to a patient with a 50-year history of chain smoking.
Exactly. The baseline assumptions are already being challenged by her profile alone.
So the medical team starts their investigation, and they eventually find a left bronchopulmonary adenocarcinoma.
The primary tumor, yes.
But they also find the active tuberculous lymphadenitis. You mentioned earlier that the scans blend these two things together. Let's look at the actual methodological considerations here, the medical imaging journey.
Let's do it.
Because if you've ever had a loved one go through oncology screening, you know that a PET-CT scan is treated as the ultimate source of truth.
Oh, absolutely. It's the gold standard.
They inject a radioactive tracer, usually a type of modified sugar, and then scan the entire body.
Fluorodeoxyglucose, to be specific.
Great.
And it is a brilliant piece of diagnostic engineering. You see, cells that are dividing rapidly and aggressively, like cancer cells, require immense amounts of energy.
They're metabolically hungry.
Incredibly hungry. So they pull in massive amounts of that radioactive sugar, which causes them to literally light up on the resulting scan.
And the PET-CT scan did its job perfectly for this patient, didn't it?
It did. It spotted highly metabolically active lesions in her lung and, critically, in the adjacent lymph nodes.
So the scan points the finger at the lung and the nodes. But this goes back to our orchestra analogy.
Right, the oboe and the clarinet.
Exactly. The machine is detecting rapid energy consumption. Cancer cells consume energy rapidly to multiply. But an active immune response fighting a bacterial infection
Also requires a tremendous amount of energy.
Right. So the tuberculosis bacteria multiplying those lymph nodes triggers a massive, desperate immune response.
All those macrophages, the T cells, all the biological machinery rushing to that site to fight the TB, they're consuming that radioactive sugar just as greedily as a tumor would.
So to the radiologist looking at the scan, the active TB in the lymph nodes and the adenocarcinoma in the lung emit the exact same visual signal.
Exactly the same. The machine can tell you there's a raging fire in the building, but it cannot tell you if you're looking at a grease fire or an electrical fire.
Wow. So relying on that scan alone would have led to a catastrophic misdiagnosis. They would have assumed it was late-stage, spreading cancer.
And that's the staging trap. But the physicians in Rabat recognized this limitation. They knew they had to look at the actual cellular structure, not just the metabolic shadows on a screen.
So what did they do?
They performed a CT-guided biopsy. They used the scanner in real time to thread a needle directly into those glowing nodes and extract physical tissue.
And then they send that tissue off for histopathological analysis.
Right.
Putting it under a microscope so a pathologist can actually look at the physical architecture of the cells.
And under the microscope, the dual diagnosis finally revealed itself. They identified the malignant cells from the primary lung tumor, but the tissue pulled from the glowing lymph nodes told a completely different story.
There were no cancer cells there at all.
None. Instead, the pathologist saw the unmistakable biological hallmarks of tuberculosis, the specific type of inflammation and cell death associated with those broken-down granulomas we talked about earlier.
That's incredible. Now, I know oncologists generally stage cancer from stage 1 to stage 4, but this paper keeps harping on something called TNM clinical classification.
Yeah, TNM is crucial here.
How does a swollen, infected lymph node hijack that specific staging system?
Well, TNM is the structural foundation of all cancer staging. T evaluates the size and direct extent of the primary tumor
Okay.
and evaluates the regional lymph nodes to see if the cancer has reached the lymphatic system. And M checks for metastasis.
Meaning the cancer has seeded itself in distant organs like the brain or the liver.
Exactly.
So the N is basically the local neighborhood watch. If the cancer hits the nodes, it has access to the highway system of the body.
That's a great way to put it. By standard textbook protocol, if a primary lung tumor is visible and the lymph nodes on the exact same side of the chest are enlarged and glowing on a key scan, the clinical presumption is malignant spread.
Right, so the N value increases.
And the moment that cancer is staged as having spread to the nodes, it transitions from being a localized, potentially easily removable tumor to a complex, advanced regional disease.
And this is the trap. A false alarm in the biological security system completely alters the patient's treatment trajectory. If a surgeon believes the cancer has already extensively invaded the lymphatic system, they might determine that physically cutting out the lung tumor is pointless.
Yeah, the patient could be denied a potentially curative surgery because the doctor just assumes the cancer is too far gone.
Which raises such an important question about system-level reflections. How many patients globally are receiving inappropriate, dangerous treatments because of undetected concurrent infections?
It's a terrifying thought. If the Moroccan doctors had skipped the biopsy and just trusted the PET scan, they would have subjected this 71-year-old woman to heavy, aggressive chemotherapy meant for late-stage cancer.
And chemotherapy works by indiscriminately attacking rapidly dividing cells, which heavily suppresses the production of new white blood cells.
Right, it wrecks the immune system.
So if you obliterate the immune system of someone who is secretly harboring an active tuberculosis infection, you are destroying their body's only defense.
Exactly. The immune cells keeping that TB in check would be completely wiped out. The tuberculosis would just run absolutely rampant.
So the prescribed treatment for the misdiagnosed advanced cancer would become the very mechanism that allows the hidden bacterial infection to kill the patient.
Which is exactly why the authors emphasize this. Whenever lymph node tuberculosis is even a possibility, nodes on the same side as a primary lung tumor must be microscopically verified. You just cannot guess.
Okay, so the doctors avoided the trap. They did the biopsy, they proved the cancer's localized, and they proved the lymph nodes are swollen purely because of TB.
A huge win for the diagnostic team.
Definitely. But now we face a massive logistical nightmare regarding the institutional and policy implications. How does a medical team actually treat a patient who is simultaneously fighting a localized malignant tumor and a massive bacterial infection?
Yeah, you can't just fix one and ignore the other.
Right. It's like trying to put out a fire with water, but there's an exposed electrical wire right next to it.
I love these analogies today.
Thanks. I mean, you need to treat the cancer, but the cancer treatment shorts out the immune system. You need to treat the TB, but the TB drugs have their own severe collateral damage.
They absolutely do. The paper outlines a highly synchronized multidisciplinary strategy. This patient requires a medical team acting with extreme coordination. They have to balance the anti-tuberculosis therapy with the oncological treatment.
Because the physical toll of anti-tuberculosis therapy is profound.
It really is. It isn't a simple 10-day course of standard antibiotics. We're talking about a grueling, multi-drug regimen that lasts for many months.
And these drugs are notoriously hepatotoxic, right? Meaning they put an immense strain on the liver.
Exactly. The patient's liver is working overtime just to process the medication without failing.
And then, while the liver is already maxed out fighting the TB drugs, you have to layer on the cancer treatment.
That's why the sequence of these interventions is incredibly delicate. Depending on the biopsy-confirmed stage of the cancer, treatment could involve surgical resection.
Which is physically removing the lobe of the lung.
Right. Or it could involve targeted therapies. But putting a patient under heavy anesthesia for major lung surgery requires strong liver function and cardiovascular stamina.
Both of which are compromised by the TB and the anti-TB drugs.
Precisely. The doctors have to aggressively attack the bacteria to stabilize the patient without degrading her physical resilience so much that she can't survive the surgical removal of the cancer.
They are managing two competing biological crises in real time.
And if we connect this to the bigger picture, the sheer complexity of managing this dual diagnosis really explains why the epidemiological context of this paper is paramount.
Right.
The authors aren't just presenting a singular, interesting anomaly from Morocco. They're issuing a broader warning regarding global health strategy.
Yeah, the paper explicitly frames this within the context of the Moroccan Ministry of Health's National Strategic Plan for 2024 to 2030.
Which focuses heavily on the prevention and control of tuberculosis.
Because Morocco represents a region with a moderate incidence of TB.
Exactly. And when medical professionals operate in regions with moderate or high TB prevalence, they cannot afford to rely on Western-centric medical assumptions.
That's a huge point.
Traditional Western medical training, which was largely developed in areas where TB is relatively rare, conditions doctors to view an enlarged, glowing lymph node near a lung tumor as definitive proof of cancer metastasis.
But in a region where TB is actively circulating, that textbook assumption is fundamentally broken.
It is. The baseline probability shifts. Doctors have to treat tuberculosis as a constant suspect, even when they're staring directly at a confirmed cancerous tumor.
And to combat this, the paper suggests a very specific, proactive defensive measure for populations in these regions, right? Analyzing bronchoalveolar lavage fluid for the Mycobacterium tuberculosis bacteria.
Yes.
For those trying to visualize this, a lavage is essentially a deep lung wash.
Right, a wash.
A doctor passes a bronchoscope down into the airways, squirts a small amount of sterile fluid into a specific segment of the lung, and then immediately suctions that fluid back out.
And the retrieved fluid captures whatever cells, proteins, or microorganisms are hiding deep within those alveolar sacs.
Which is brilliant.
By actively testing this wash fluid for TB, in patients who are being evaluated for lung cancer, doctors don't have to wait for an ambiguous PE scan to confuse them.
They can proactively identify the dual reality before any treatment decisions are made.
Exactly. It changes the entire paradigm from reactive guesswork to proactive verification.
It shifts a patient's prognosis from, untreatable spreading cancer to treatable localized cancer complicated by a treatable bacterial infection.
And that shift is entirely dependent on a doctor refusing to trust a shadow on a screen. Radiologic imaging, despite its incredible technological advancement, ultimately just provides us with a map of metabolic shadows.
Right. It requires human interpretation.
Exactly. Human tissue, analyzed under a microscope by a skilled pathologist, provides undeniable biological truth.
So what does this all mean for our system-level reflection? When we look at the totality of this case report by Casa Bucat and the medical team at the Military Teaching Hospital Mohammed V,
the core takeaway is a stark warning about diagnostic deception. Clinical presentations and advanced radiological scans can be incredibly convincing liars.
they really can.
When lung cancer and active tuberculosis exist side by side, they mimic one another, they amplify one another's signals, and they can easily trick even veteran diagnostic teams into making fatal staging errors.
So the absolute necessity of extracting physical tissue through CT-guided biopsies to ensure accurate TNM staging is really the paramount lesson here.
It is a humbling reminder that the human body doesn't abide by the clean, separated chapters of a medical textbook.
Definitely not.
It's perfectly capable of hosting two distinct, lethal anomalies at the exact same time.
Which leaves us with a really profound reality to consider about the future of global medicine. As international travel increases, as migration patterns accelerate,
And as the traditional boundaries of infectious diseases are redrawn by climate change and urbanization.
Right, the neat borders separating high TB prevalence and low TB prevalence areas are just disappearing.
The epidemiological pools are blending together. A doctor in New York or London might soon be facing the exact same baseline probabilities as a doctor in Rabat.
Which means we have to wonder how many seemingly clear-cut, late-stage cancer diagnoses happening around the world right now are actually illusions.
It's chilling. How many patients are currently being sent to palliative care with their tumors deemed inoperable because of glowing lymph nodes, simply because a medical team didn't realize the oboe and the clarinet were playing at the exact same time?
That is a haunting thought, but it completely changes how we should view medical certainty. You always have to listen closely for that discordant note.
Always.
Thank you for listening to the GMJ podcast Health and Migration series. For a full and detailed discussion of the topic presented in this episode, We invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.